So you will see that this course, perhaps more than others we've done, has a little bit of a bent towards hospital medicine. I want you to understand your hospital medicine colleagues, because overwhelmingly, who are you admitting to from the ED? Right now, most places, about at least 40% of admissions are going to hospital medicine, and I think that's a trend that you're going to see. Even aren't you seeing a broken hip go to hospital medicine with the orthopedics consulting? Am I right about that? Is that your experience in the room? Yeah. And I was thinking about how I'd phrase this. How many of you are not dealing with boarding in your emergency room, holding admitted patients first? Anybody? Yeah. So fair to say that it's a problem that we do not cause, but it surely plays out in our domain, doesn't it? And so I want you to be the smartest person in the room when you go back and you're at a meeting, high-level meeting in your hospital, to look at admissions and look at boarding. I want you to know something about it, a little more than you did when you got here, because I think it'll serve you well. The other thing that I wanted you to know is, y'all are being groomed for higher positions. Do you know that disproportionately, people that are leaders and managers in EDs and both physicians and nurses, we are disproportionately called on and pulled up into leadership roles in the hospital. I know many medical directors of ERs, physician medical directors that go on to be a CMO. I know nursing leaders of the ER that go to the next VP position, then on to CNO. Do you know that? Why? We're good problem solvers. That's what we do. That's our forte. And so I want you to understand some things about boarding that you might not understand. I used to feel like, hey, listen, CEO and CNO and CO, get these admitted people out of my ER. Get them out of here. Put them upstairs. Put them in the hallways. I thought that it would be a quick fix. Actually, it is not such a quick fix. On the other hand, it is fixable, and that's what I want to try to convince you of here. So today we're going to talk about what do we mean by discharge delays? What do we mean about disequilibrium? That's a term that's now in the literature. What are some strategies that can help open up beds for you, which you desperately need? What would a change package look like? And then I want to show you one institution that has done an amazing job at improving their boarding problem. So discharge delays. Here's what the literature tells us, and this may surprise you. More than 20% of an inpatient length of stay is due to a discharge delay. That means the patient is medically ready to go home, but things are getting in the way from sending them home. It's very expensive to do this because hospitals are quite an expensive hotel. Try $2,500 to $3,000 a night. That's how expensive a hotel we are. 25% of occupancy is caused by discharge delays. So I want you to do this in your head. At your hospital right now, 1 in 4 patients does not need to be in that bed. Don't you find that shocking when capacity is so tight? But this is what the numbers are showing. And about 1 in 4 SICU days is avoidable. The patient could be moved on. Why? What happens to the patients that need to come out of the ICU? Sometimes, I never thought I'd see this. Like old days, coming out of the ICU, you'd go to a step-down bed or you died, right? Is that how you got out of the ICU? Now, do you understand this? You have ICUs discharging to home, and they don't know how to do it. They're like, you've got ICU docs that have never written a discharge prescription set or package in their life. This is how, because of the capacity issues that we are all experiencing. So the literature shows, and it's interesting, it's kind of a mirror to boarding. Discharge delays are associated with adverse events, increased costs, increased morbidity, increased mortality. There was a study out of the UK that looked at, as discharge delays occurred, mortality went up at the hospital study. This is the real deal. Why? The same thing happens on the inpatient side as it happens to us with our boarders, right? We don't mean to do them harm, but we kind of forget them, right? Oh, he's being admitted, he's going upstairs. Similarly, on the inpatient side, if I'm a hospitalist or another inpatient doctor, I'm thinking, oh, he's discharged. nurses are thinking, oh, he's going home. We forget to feed them. We forget to medicate them. Oh, by the way, we let them fall. So bad things happen to them on the inpatient side when they're ready to go home and we don't get them out. Why can't we get them out? What's this about? Well, so who remembers the old days when you're going to discharge a patient? This would be Dr. Welch as a young doctor with a ponytail in her Adidas running around doing inpatient medicine. I got a piece of paper, it was pink, and I wrote and I pressed really hard so it made 3 copies. Anybody remember this? I'm really dating myself, right? Anybody remember this? And I would write DC to home. And that was my discharge plan, and there they were, and they were expected to go. Well, we subsequently realized that doing it that way, what was happening on the other end? We'd send them out, and then what would happen? They all came back, or at least 1 in 4. Readmissions were tracked by CMS, and they went, oh my God. Patients were being readmitted, 25% of them within a month. Isn't that shocking? So now we pay a little more attention to that whole discharge, planning it, trying to make it so that patient does not come back. Why do we have trouble getting them discharged? Communication is one thing. I will guarantee you, if you go to one of your inpatient units right now and look and say, how do we know who's going home today? Or how do we know who's going home tomorrow? Look in Epic, right? Isn't that what you get? Like, there's no place that we can orient the work to get somebody home on the inpatient side. So communication is poor. The processes, who's supposed to do what? To get somebody out the door and home requires a lot of things to be coordinated. We need a ride, they might need medicines, they might need a walker. And all of these things create barriers, so they're ready to go, we can't get them out the door. Sometimes we need last minute things like, I don't know if you realize this, but consultations are becoming a barrier to discharge. They're a barrier to you in the ER, but they are also on the inpatient side. You have patients sometimes waiting a couple of days for recommendation from a consultant. What about transportation? Everybody works. Who's going to take grandma home? And so are you aware that Uber is getting into the discharge transportation mode? There are companies that are developing. I know in Richmond there's one that's just for medical transport home for people that aren't terribly sick and they don't need a squad or anything. I saw this was actually an academic medical center in Richmond. Someone coming in at 5 o'clock. I took a picture of it because it was a great picture with walkers over each arm, like a dozen walkers. I took a picture by the elevator with the walkers at 5 p.m. So that's a lot of beds that could have been opened up, but they needed a walker to go home. And then more and more, especially during COVID, we got into the, let's give people their medicines before they go home. So all of these things make it hard to get people out the door. And then there's those difficult dispositions, right? The ones that are waiting for placement. During COVID, it was impossible because they wanted yet one more COVID test before they'd take a patient into a nursing home. So difficult placements create a problem. They suck the oxygen out of the room. You have patients that, I'm sure you know this, that have length of stay of like 102 days because we can't get them placed. There's data that identifies these for us, and they're particular categories. Homeless are very difficult to place. Anybody with psychiatric diagnosis, anybody with dementia, people with comorbidities, and in particular, people who have a history of violence. They are hard to place. That said, and I've surveyed this on many inpatient hospitals, I've surveyed, why can't you get your people out? And everyone will tell me, oh, placements. We can't get them placed. And it is true that we are largely underserved for these kinds of facilities, right? Nursing homes, where most communities are woefully underserved. But are you ready for this? Where do people really go from the hospital? And I've done this at many institutions. I think this was actually San Antonio, and you're going to hear from San Antonio people. If you look at that large bar, that's who's going home. Right next to it, going home with home health. It's not the difficult dispositions, my friends. It's the people that are literally going home, and I have seen firsthand somebody not go home because they didn't have shoes. I said, I'll go to Walmart and buy you some shoes for $2,500 a day. That would be cost effective, yeah? right? Should we have a shoe closet? I don't care. I mean, there's certainly solutions other than that. I've seen people waiting for walkers, waiting for a ride, waiting for medications. Sometimes everything's ready and we're waiting for the inpatient doctor to write the order. And I have a hospitalist friend right in the audience, so I'm saying that for him. Waiting for that order, but more often it is these little things that are keeping somebody in a bed, and you want to know what the problem is? You need that bed. You need that bed. So, useful observations. Most patients are going home, and they forget that on the inpatient side, and I have to sort of reorient them. A small percentage of patients cause so much anguish and grief, and like I say, suck the oxygen out of the room. We need to look at transportation in our community. Sometimes, get this, the family doesn't know. Mom's going home? Wait a minute, nobody told me, because of this communication breakdown that we have. So all of these things are contributing, and we'll talk a little bit about care coordination, the role that it plays in that. Now, what do I mean about disequilibrium? And this is fascinating, and I find this every facility that I go to. You have a disequilibrium by day of the week. More people are coming in at the beginning of the week, and more people are going out. I say people like their weekends. That's my theory of why that's so. They like their weekends, they want to get home for the weekend. But this mismatch we see day by day across the country. Anybody think they don't have this mismatch? You know what days of the week is it hardest to get your ED patients upstairs. This is part of the reason why. All right, then look at this. This is just fascinating. This is looking, gray is admissions. Notice that the admissions in a 24-hour period never stop, right? We're admitting people from midnight to 7, 8, 9, right? So all those people that are getting admitted, no one is leaving to open up for them. Your white is your discharges. What's going on at 11? This is hospital-wide data. There are certain specialties that literally schedule their discharges, and that would be obstetrics and peds, especially newborns, right? So that accounts for that. Also notice we'll often find around 5 in the morning a little admission blip. Do you know what that is? That's procedural admissions. They dump in by convention at around 5. So I always see that little blip, like, what's that? Is the ER all of a sudden sending a lot of people up at 5? That tends to be procedural admissions. So again, see this mismatch, and I want to show you this is a typical emergency department. They are not opening up beds for everyone who's come since midnight until about 3. So can you see how that's a problem? Not enough people have left. Oh, by the way, then once they leave, what's got to happen? Got to get the room clean. Do you also know this? Most of housekeeping leave at 3. Did you know that? Housekeeping tends to be a lot of younger people. They have young families. They want to get home by the time their kids get out of school. But how does that work for us, it being a 24/7 proposition? So isn't this fascinating? It's kind of a wonder that you get anybody upstairs, yeah? Right? It really is a wonder. So I tracked this. This was, I think, in Richmond again, a couple years ago, and I've seen it over and over, the different admission to discharge patterns by hour of the day. So remember I told you, OB and peds, they rock it. At 11 o'clock, man, you're out of there. Now, truly, that's a different specialty, isn't it? Those people want to go home with their babies, right? They want out. That may be different than other specialties. But I wanted to show you, look at hospital medicine, which is in the upper left corner. They're not really doing the bulk of their discharges until about 5 o'clock. And what have you needed since you came on your shift today? You've needed to admit your medical patients, and so they've been boarding. And so could we start to improve on this? And IHI says yes, we should all be moving towards absolutely scheduled discharges. Why can't we get a handle on this? We can't control the admission curve, but we can control discharge curve, or we should be able to. So what are some of the strategies that work on the inpatient side? So I like a core project where we tackle head on what has to happen before this patient goes home. What's the process? And who does what when? There's a nice dance, a choreography we've got to do to get somebody home. How do we know who's going? Can we improve the communication? What would that look like? How can we make it? Could you see a time where The whole team would come into work planning to go. So I'm imaging. When I go to a floor, I look at who are we trying to get home, and I do them first. I'm EKG. I look at who's going home. I'm going to try and get that person first. Lab. How about I do all the labs on people that we're trying to get home today, early in the morning? This is doable, my friends. But right now what I find is most places, unless you open up record by record, you don't know who's going home on the inpatient side. So that's hard for us to do that. There's something called discharge rounds that I'll talk to you about in a second. And the idea that we actually come together and talk about who's going home on the inpatient side. And then different tools, checklists and so forth have been developed that help this. So this is just showing you a discharge matrix. What if we mapped out for every unit, and I've actually done this unit by unit in large medical centers, from admission until they go home, role by role, who's going to do what? We need this. We need this, or how are we going to make it happen? And so, it's astonishing that we don't have this, right? It's really astonishing that we don't have this. This is showing you another way of swim lanes. What does the patient and family do, provider, RN, care coordinator, and so forth, starting a couple days up front? Because you want to know what happens when a doctor writes an order for the patient to go home? Does the patient go right out the door? Oh, no. In fact, most places it's at least 3 to 4 hours to get them out the door, if they can even make it happen. And so writing the order, how many of you know this? Are you tracking at your hospital discharge order by 10? Anybody know this? Sometimes they incentivize hospitalist doctors to write their discharge orders. And guess what? They play the game. 9:59, they're writing discharge orders like mad, and the patients and the family don't even know they're going home. Nothing's ready. It doesn't matter. They don't go home until tomorrow anyway. But they meet the metric. So you're going to go back and you're going to talk to your CEO and say, hey, let's stop this discharge order by 10. Let's do discharge by noon, but out of the bed by noon. Empty bed by noon. That's what we should be tracking. That's what's going to make a difference. All right, discharge communication. There's only so many ways you can do it. You can send out, we know NYU Langone Medical Center, when they first started doing their discharge by noon work, they sent out a mass email of who's going home today so that everyone was informed. You can do it whiteboards, which I like them as an adjunct. Did you know if you simply have a whiteboard at a patient's bed, the head of the bed, and put on it when you think that they are going to go home, it drives the process. Because now the family says to theirs, hey, did my mother get her diabetic teaching? She's supposed to go home tomorrow. It says on the board she's going home. So discharge whiteboards actually are effective. And how's that for a low-tech solution? There are many, many ways you can do it, but we need something to tell. Now, at San Antonio, we're going to hear, University of Texas San Antonio, you're going to hear later from their COO, Ed Banos, they actually used color-coded papers. If you're going home today, there was a green paper attached to the back of your door in your room that had a little checklist. If it was tomorrow, it was yellow, and they've expanded that color code. And actually, this is so funny. Patients got hip to it. They're like, hey, my roommate's got a green paper. When do I get my green paper? It just was a visual cue that helped get the team organized around that discharge. The other thing that we need to do is we need to start talking about patients going home the day that they come in. And a lot of times you'll find the staff don't want to go out on a limb. And I said, look, you can tell them they're going home Wednesday. If we don't make it till Thursday, fine. But let's at least be shooting for something. The patient should know, their family should know, all the staff should know. The other thing that we ask our hospitalist colleagues, and mind you, they are like our cousins, and we should view them that way. We are young specialties. We are hospital-based. We practice in a fishbowl. We have a lot in common with hospitalist medicine. Typical hospitalist medicine workflow involves coming in, seeing new patients, then doing your work rounds, then doing your discharges. We ask them to flip it. Could you get your discharges for tomorrow ready today, all the paperwork and whatever else, and then come in the morning and do those discharges first? And when you can get them to do that, that is a very powerful change, a change in the workflow. It's not an easy change. It involves a cultural change, and actually, Dr. Vasquez will probably speak more about some of these issues. Now, there's something else afoot around the country where they're getting this down, and that's called flash discharge rounds, okay? So what it is it's a rounds that's not work rounds, it's not bedside rounds, it's usually tabletop. where the right people on an orthopedic floor, it might include physical therapy, they come together, case management, nurses, and so forth, and say, who's going home tomorrow? What do we need to do to make that happen? Who's going home the next day? What are the barriers to discharge? So these flash rounds are very effective. There are some other small projects that can go hand in hand with this larger project. I wanted to let you know that your care coordination is growing now. It's formerly case management. This is the new jargon. It's a new specialty. It used to be, Mike Gibbons always says, it's where nurses and social workers go when they want to retire. They go to case management. Not so anymore. It's a robust field, it's really growing, but we're starting to realize we need case managers that specialize in those difficult placements, and we need really clear role clarification about what they're supposed to be doing. I like care coordination to not only help with discharge management, but I like them to help with throughput support and help chase down the very many things that we need to have to get a patient discharged, push it to the provider. All right, geography, I'm not going to spend too much time on this because Dr. Vasquez is going to talk about what we mean by that, but what we mean is putting a doctor with a team on a floor, or maybe 2 floors. Do many of you know that hospitalist medicine moved away from that as bed capacity became tight? And now they're rounding on, I've known some hospitalist groups that are rounding on 11 floors in 2 different towers. Is that crazy? They're not with a team, and that's why the communication breakdown has, I believe, contributed to longer lengths of stay. So John will go through this, but there's lots of pros to geographic localization. DME, can we solve that problem by just having a closet full of DME? Why not? So when the patient needs it, they've got it. Consults, I'm seeing a lot of hospitals start to focus on how can we make consults more expeditious. One thing you can do is set a timeline, like most of you have in your bylaws that your consultant must respond to the ED in like 30 minutes or an hour. Don't you all have something like that in your bylaws? What about on the inpatient side, a time for consultation, especially a pre-discharge consultation? So Consults Improvement Bundle can include a lot of these things. I'm making myself stick to my own schedule here. These are smaller improvements, but the last thing I want you to understand about improving discharge is this. We measure boarding in hours, admit decision to departure time, and boarding hours. The highest I've heard is 14,000 boarding hours a month. Anybody beat that? Oh, gosh bless you. That's hard. Okay, what are you at? 16 or 17,000 boarding hours. Oh, yes?
20.
Oh my gosh. Just when I think it can't get worse, it gets worse. Okay. So we measure that. What do they measure on the inpatient side? They measure observed to expected length of stay. Okay, that's how long is the patient staying. I worked with a hospital last year, 1.59. Oof. I'm worried they're going to go under if they don't fix that. Observed to expected. You want that to be 1 or less. Discharge by noon. Do you all know what your discharge by noon rate is? It's probably under 10%. Taking it higher will make a great difference to the ED. On the other hand, what about it's in balance with readmissions? If you are pushing people out too fast without coordinating their discharge, they will come back and be readmitted. And you don't want your readmissions to go up. So these are the things that hospitalist medicine is being tracked on and measured on. This is real results. This was the University of Texas, San Antonio teaching hospital, hard to do this kind of work. And this is showing you how they took their discharge by noon to over 30%, doing some of the things that we just talked about. And by the way, people from the ER were hugging the senior leadership of the hospital because they felt it. They had beds for their patients. Their ER could now hum along because of this work. So I just want you to know, it's fixable. I want you to understand what's on the table and how you make this happen. And I think you should take these ideas back to your home front.